Um, we're on the path of this convergence of three technologies, beginning with customized electrodes, selecting the electrode through Otoplan, and once we have it, we're redefining soft surgery through motorized insertion in OtoDrive. And then Jennifer talked very nicely about filling a void in intraoperative objective measures. So let's start with the first step, and that is picking the right electrode. We in Canada and most of the United States, unless you have a customized Otoplan, we're sending images to Otoplan on demand and getting a package of information back. And we understand that this is constantly being upgraded based on new information. And some of the new information that emerged from the HSP meeting in Niagara Falls were from Professor Usami and Kevin Brown with regards to scalar height and scalar volume. That seems to be very important, especially as we talked about the second turn, the apex of the cochlea. And then privately, Sumit and I have talked about, well, there's a round window issue that we need to resolve. So he's going to tell us about whether he has enough synchrotron data and clinical CT information to add this to Otoplan in terms of assessment.
All right, so I didn't actually have anything prepared to say, but we'll kind of go off the cuff. So I think first talking about electrode choice, I thought I had a paradigm in my head, but then we came to this meeting, and after hearing all of Professor Usami's data and about being able to predict who has a progressive loss versus not and their groups, I think it's kind of changed my paradigm. I'll be honest, in Canada, we don't do genetic testing in advance. So when people who have partial preservation, we typically aim for longer electrodes. And that goes to what Meg Dillon was saying yesterday, where, we don't like having a gap. We like, over-inserting and then deactivating the apical electrodes, just so we have a backup that if their hearing drops, we can now activate those electrodes without having to reoperate. So that's been our classic paradigm in terms of a prediction. But I think now with genetic testing and everything else coming up, I think we have to be a bit more sophisticated, because until now we've just taken kind of a one-size approach. In terms of electrode selection, I think yesterday in the Apex panel, it's pretty controversial. As we found afterwards, it's not a universal, agreement as to where to go. I think we have, Professor Mueller has done, great work on the Flex 34 and, has been aiming for that full 690-degree coverage. I think we have other ethnic groups, I don't know if Professor Hodger's here, but where, they're getting a lot of incomplete insertions, even with Flex 28s, and have moved to putting in Flex 26s. And so they're not aiming for that deep of an insertion. So I don't know what the right answer is. And in our clinic, like I said, our magic number, which isn't really based on any empiric data, but just looking at scala tympani, height and volume, we've been aiming for 630 degrees as kind of a balance between the two, to get enough electrodes up into the region where you get down to 200 hertz, which seems to be where the fine structure works well. So, but that varies by patient. So I think Otoplan now, they have implemented, I know Masood is here, but they have implemented a lot of our synchrotron data and synchrotron studies into the algorithms of Otoplan. So Otoplan has become much more accurate for people who are using the latest version. Cochlear duct length measurements are much more accurate. We now have averages between scala tympani and scala vestibuli, and we could look at scala tympani volume. That came up in Niagara Falls, and I know Kevin Brown has some really nice data looking at scala tympani volume for hearing preservation. I think there is still a little bit of a estimate error. I know Masood and I have talked about that a bit. I think errors are up to 30%. Sometimes Otoplan will overestimate where you're going to get, and then when you actually put it in, you may be 30% off. So I think there's room to improve Otoplan in terms of the prediction of what your angular insertion depth is going to be. So those are kind of my takeaways on volume and imaging. I think Otoplan's getting better, and hopefully, as we've been discussing at this meeting, Masood and I, that hopefully we can get some deep learning into Otoplan to get some more direct measurements right out to the apex. My final word on the round window, hopefully by the time we have hearing next year, hopefully we'll have some nice round window papers out that we're actively working on. The round window is complicated because it's not just the round window size. The round window size is not correlated to the size of the cochlea, and we've looked at that across over 100 scans. So you can have a very big cochlea and a very small round window, and conversely, you can have a very small cochlea and have a very big round window. And we thought they would be correlated, and they're not. So I think we have to do some more direct measurements of the size of the round window, but I think more than the size, it's all the angulation between the round window and the scala tympani. And if you have a very unfavorable angle, the electrode has to do this 90-degree shimmy to get into the scala tympani. I don't know of a better terminology to really describe it. So I think if we can predict that in advance, we may know which electrodes might have a little bit of that incomplete insertion where that 12th electrode is just very hard to get in, and then other cochlea, it feels like the whole thing glides in, even when you know you have enough room in the scala tympani. So I think that's more work to come. I don't know if I answered your question, but.
Thank you, Sumit. This is clearly work in progress as we continue to prioritize angular and depth of insertion, also with full insertion, and that's important, so we need more data. I'm going to switch gear to talk about surgery, and I think there's enough evidence from the Bernice group that intracochlear pressure peaks and insertion force dramatically reduces with a motorized insertion tool. The data from Iowa, the data from Toronto and London showed that there's a very dramatic improvement in translocation injury. I think the evidence is there. The question is this the new way of doing soft surgery for every patient, especially now genetic treatment is just around the corner, especially in the pediatric patients.